Good afternoon, everyone. I know we still have several people filing in. We expect a large group today, but in the interest of time, we are going to go ahead and get started. Good afternoon and welcome to today's webinar. It's hosted by the Georgia chapter of HFMA. I'm Laurie Hebe with Clear Balance, and I'm a Georgia HFMA Education Committee volunteer. Today's session focuses on revenue recovery during the pandemic with noted speaker Jonathan Wiik of TransUnion. Knowing that this is a topic on everyone's mind, we're also welcoming participants from our neighboring HFMA chapters across the Carolinas, Florida, Alabama, and Tennessee. And in fact, today's session really is somewhat of a precursor to a collaborative activity that we're going to be launching as Region 5 next month. It's going to be a Region 5 virtual day, and that date is Tuesday, July 14th. Each of the regions will host a webinar throughout the day. We're getting started with that right now. We're putting everybody's sessions together. So please be on the lookout for more details in your chapter e-newsletter and in upcoming Region 5 emails. Before we get started today, I want to review a couple of housekeeping items. As you know, all phone lines are on mute to avoid interruptions. Please submit your questions via the question box at any time, and I'll coordinate with Jonathan for his answers at the end of the presentation. I am sending now, posting this link. I just put it in the Zoom webinar chat. It's a link to Jonathan's presentation. You'll find it on the Georgia HFMA library. You start at the media tab, and you see I've given you the drill down there for that. And we will also be putting the recording link in that same area later this week. Everyone on today's call is eligible to receive continuing education credits. Be on the lookout for this form. It'll come in your email, and you'll use the form to self-submit for your credit on the HFMA website under the membership info tab. Now it's my pleasure to introduce our speaker. Jonathan Wiik is Principal of Healthcare Strategy at TransUnion Healthcare. Jonathan has almost 25 years of healthcare experience in acute care, health IT, and insurance settings. He started his career as a hospital transporter and served in clinical operations, patient access, billing, case management, and many other roles at a large not-for-profit acute care hospital and also at a prominent commercial payer before serving as Chief Revenue Officer. In his current role, Jonathan supports and consults on business development opportunities and works closely with the market and hospitals on industry best practices for revenue cycle management. He is considered an expert in the industry for healthcare finance, legislation, revenue cycle management, and strategic transformation. Jonathan is an active advocate of legislative changes that evolve the healthcare industry. He's also the author of Healthcare Revolution, The Patient is the New Payer, and his new book, Revenue Evolution, Helping Providers Get Paid in an Era of Uncertainty, which was released earlier this year. He speaks frequently as a thought leader at state and national events, and Jonathan currently serves as an officer on the Colorado HFMA board. Jonathan, thanks again for joining us, and we're ready to begin.
Great, thank you so much, and thank you, Region 5, for having me. I hope this is a relevant conversation for you and helps generate some thoughts and questions towards the end. I do have my bio up here, my contact information, 2 I's and a K. Or if you are interested in these books, let me know. I'm happy to have some dialogue with you and ship you one. Us getting them over to Amazon's been a little challenging now. I know you can order them there, but it's funny, the orders kind of come back to me just because of how we have them stored. So give me a call or send me a note, and happy to be here today. And it's funny, my second book, I swear I didn't know that COVID was going to happen, but it certainly is an era of uncertainty for payment right now, and it's got some good strategies in it to talk through how you can get your revenue cycle back aligned to profitability. We're going to talk about infection rates and testing right now. I think there's a lot of we know going on with COVID. Just a high level, we're certainly on the downstream or backside of the dome. It may uptick. I've talked to probably no less than 3 or 4 dozen CFOs across the country in my role, and most of them are budgeting in their Q4 forecasts for a resurgence of some sort in terms of having PPE and maybe a decline in elective procedures as well, and possibly a surge in inpatient COVID presentations. Not nearly what they probably saw in March and April, but certainly are being conservative in terms of where they're at. New York Times does a pretty good job of tracking the overall case rate and the death rate. This is just a snapshot from yesterday or earlier this week. but we are seeing a leveling. You'll notice, that the downward slope is much less steep than the upward slope, and I think we're going to, probably end up, in the 4,000 to 5,000 case per day rate, as the fall comes in, unless we get into a resurgence. But I think we might also see a little hockey stick or a pig's tail come up here a little bit as we open up economies and start relieving some of the social distancing. So we'll see where we end up. One thing that's important in all of that is testing. I think that's kind of the key to the kingdom with COVID-19 and our future. It's something we're going to have to learn to live with as a country, and how we operate our health systems and our revenue cycles is going to be fundamentally changed, I would argue, forever, because of some of the things COVID has brought forth. Right now, or as of earlier this month, we were processing as a country about 464,000 COVID tests a day. There's been some studies done at MIT and Johns Hopkins University and several other organizations that have said the magical numbers just over 900,000 tests per day to be able to have a good sample size and assessment to understand where COVID is, how it's doing, how antibodies or people that had it already, how the herd immunity, if you've heard, is progressing, and where there are pockets of outbreak. And so we're about halfway there. And you could see that trend will probably put us into October, November, if I had to guess, before we hit that threshold. It's just taking an inordinate amount of time to get these testing up to speed and getting them to where places are. Most communities that I've talked to, at least in metro areas, have a half a dozen to a dozen kind of drive-through COVID testing areas. They typically are limited to populations that are experiencing symptoms. There isn't really a free-for-all out there, which is what I feel we ultimately need to get to, as most of the epidemiologists feel that way as well. We all probably need to get tested as we start talking about, where vaccines are going to be and those types of things once those become developed next year sometime. That said, we're making some progress. This is another analysis from MIT and Johns Hopkins that shows the threshold kind of broken out by state. So that 900,000 tests distributed by the populations across there at the bottom. And then those states that have actually achieved that threshold, I've circled here for you. Some are actually in your region. I think, as states achieve this testing goal, you'll see those economies progress into those phase 2 and phase 3 areas of their reopening. Phase 2 and 3 have things like gatherings of more than 10 people, more than 50 people, retail, maybe restaurants, being able to travel. Some involve some sports and some things like that. Things like movie theaters, I would argue conferences, and other things are probably going to be one of the last lights to be switched on as this goes, and that goes for hospitals too, as far as how you're managing your waiting rooms and things, and certainly we'll entertain questions at the end of this in terms of how your intake is happening, because I happened to be at a doctor yesterday and they're scheduling every other slot, so there's no more than a certain number of people in the waiting room because they're just trying to keep people that 6 feet apart. Let's talk about impacts here. At the end of this deck, and we had sent the link out, there is a link to the briefs here as well if you want to go look at them. But TransUnion Healthcare published these 8 scenarios about a month ago, 6 weeks or so, and just talked through, hey, here's what we think is going to be happening through this surge. And we've been fairly accurate in terms of what hospitals and providers and just the general economy could expect and has basically endured during the COVID-19 crisis and recovery. Unemployment we'll talk about a little bit later. If you were in an area that was fairly populated, I believe Florida falls into that category, possibly parts of Atlanta as well, and Georgia, certainly had ED surges occur, which creates these kind of dirty claims and certainly a high propensity of denial and payment issues, as well as some bad debt. Capacity and supply chain, about it. You've dealt with that before. I think some of these things with COVID just amplified that. Staffing constraints. We talked to several different hospitals that had an infrastructure that was probably inadequate before, and then trying to make a work from home productivity model work during that model took time, whereas others we saw them move rather quickly. Most hospital financial portfolios were devastated, as with everyone else, and they're just going to try to work them back. I actually looked at my my management portfolio yesterday, and it's almost at break even from where it was in March. So there's a trough, but it's starting to come back. I think it's got about 20-30% left, and I think hospitals are trying to do the same thing too, but they took a hit as well, and that impacts their ability to borrow, and certainly the bond ratings, and that's something that's being looked at very closely. Newly insured, as you saw, we'll talk about legislation today, but as you saw with the CARES Act and the FFCRA, and HEROES even has some more language in it, although I think that bill will probably be dead on arrival once it hits the House and POTUS. But they've talked through, opening up open enrollment periods for the health benefit exchanges, certainly expanding Medicaid, increasing some payments on the DRGs for Medicare, most things you're aware of, but those things are there, and it makes important that from a recommendation standpoint that those financial assistance policies and insurance discovery processes are in place to ensure that you've got those patients enrolled and are doing what you need to do from a financial clearance standpoint. Finally, high-risk patients, social determinants of health, kind of the new black in healthcare. Certainly, I was just doing some research and found a really cool article from Harvard. I'm happy to send it along to you that talks about how poverty, whether you're a person of color or not, and where you live in terms of how dense that house is, in terms of how many people are there, have a significant impact as to your likelihood of death with a COVID infection based off of that region and where you're at. And so that population or those populations, certainly have a outreach and opportunity to be fundamentally treated differently as we incur resurgences or have a fall outbreak or others. And that's that piece. And then there's the other piece of folks that had diabetes, congestive heart failure, obesity, pneumonia, COPD, or whatever, that had recurring visits that may have been virtual in nature, or they may have deferred them in their entirety. They may have gotten an increased level of sickness or illness during this, or may have lost their insurance because of some of the disruption that had happened. And so that was another risk. Obviously, I don't have time. I could do a whole deck on these 8 scenarios. They are listed in detail in the back, but I thought it would be a good summary of kind of like what we're going to talk about today as we progress. Providers are certainly feeling the financial strain of elective procedures. Many are lost dollars. Many had to furlough their staff to manage their financial operations. Becker's has this link here. I'll show you in a minute, but it was at 100 when I started. It's at 266 as of last week or so. And advisory board, very smart guy there, Chris Kearns, who's got a great series on what's going on and how to position. I highly recommend you go look at it. You'll find it. Said that the average hospital is going to see about a 50% decline in their revenues during this pandemic. So most of these things I assume I just wanted to kind of say there's strength in numbers, and knowing that what you're experiencing is probably very likely to what another state or another community is experiencing. AHA released a report about 3 weeks ago that said that the annual or the impact from this for hospitals is going to be in the neighborhood of $203 billion from March to June, or roughly losses of just over $50 billion per month. Most of those are coming from those elective procedures I mentioned. About a quarter or so, or roughly maybe a fifth or so of the dollars lost are coming from COVID hospitalizations, direct care for that, and then PPE supplies, and then of course staff support. Those are the overtime, maybe the EAP or employee assistance programs, some of the FMLA stuff that had to be put in just to make sure that you could keep the lights on as these surges and things were happening and as procedures were out. Incentives, contract labor, that type of thing made up that other wedge. This is an interesting graph. I'm going to spend some time here and talk through this, but some fared better than others with this COVID peak. Basically, the timing of that and the timing of when the Surgeon General made the announcement in March that you shouldn't be doing elective procedures anymore because you need to conserve your supplies, and we want to flatten the curve of transmission of COVID-19. If you were in a surge state, you probably did fine. If you were in a state on the out west, for example, like Arizona, Nevada, I would put Colorado in that bucket. You waited a very long time, sometimes 4 to 5, maybe even 7 weeks of deferring of elective procedures, and that was not backfilled by any COVID cases. And that period there was a period of unprofitability or of revenue loss that was much more to deficit than states that had a COVID peak happening at the same time, like New York City, for example, or New Jersey. I would put Florida in this bucket as well. I think Georgia may fit depending on the timing. But my point is that some places had 7 weeks of no elective procedures and some places had 3 weeks. And so you're going to see a large variability in operating margin. And Kaufman Hall actually did a report that showed that as well. Very good report here. You can go look at it. They have a flash report, they call it. I actually prefer April over May, but you can go find it from a link below. But they reported that March was 11% off of last March, and then 29% was April off of last April due to these volumes. They hadn't reported May as of yet, but certainly we'll pass that along when they do. And so, these are devastating losses. I remember when I was running my revenue cycle and our CFO said that we were off of budget. It typically was in the single digits, never ever double digits in my career. And we're seeing, a third of your volume going down. So very detrimental, probably unprecedented. I hate using that word because you hear it quite a bit. Financial headwinds for hospitals and providers going forward. TransUnion's been monitoring this very closely. We've sent out a series of press releases that have been tracking the recoveries and I guess the detrimental impact of outpatient procedural deferred volumes. That range, as I mentioned, was 32 to about 60% across the country in the months of March. Compared against pre-COVID volumes that were there. So imagine a bar graph I'll show you, or a line graph here where it just completely troughs out. And I have that here for you now. So zeros there on the left, and we had separated this out by ER, inpatient, outpatient. We've actually released some other press releases that talk about what types of generations, and we are foreshadowing procedural type things. And I think some interesting things from this graph, ED volumes actually went down and stayed down and are probably going to stay down for a while. And that's pretty interesting, right? The emergency department things, kind of happen because they happen. So it's not like strokes and heart attacks went away, but I think a lot of, I'll use air quotes here, suspect or maybe unnecessary ED visits probably became a reality as people were scared to come in. They may have transitioned to a virtual care visit, maybe with the primary care physician or something else. But I think you're going to see a new normal with emergency care visits. And I think people are going to do a lot of home remedies. They're going to start going to other types of clinics and had realized that maybe they can possibly wait over the weekend or through the night before they come in for their fever or their laceration or their cough or their bumped head or whatever it is, or sprained ankle. And we're running some procedures at TransUnion. We'll certainly look at what those reports look like. Inpatient and outpatient certainly were no surprise, but outpatient recovery has outpaced the ED detriment, as you see there, and I think it'll outpace the inpatient recoveries as well, because most of the inpatient admissions, as you all know on the phone, come out of the emergency department. So you'll see outpatient probably continue to climb. This data was through the month of May, and we'll be reporting more on it probably in the coming weeks as we start finalizing some of that utilization data from our client base. One thing to keep in mind in this is, and a grain of salt, is the overall claim volume as it relates to the COVID claim volume. And this is national data. It may be higher propensity at your organization based off of how many patients you saw and what was happening there. But the CAQH releases a report every year on all the claim volume, and that's about 1.6, 1.7 billion per year. We amortize that from March just to make the data similar to this AHIP report that was out there. And basically that means that between the month of March of this year into all of next December of 2021, there's going to be about 3.1 billion claims going back and forth between providers and insurance companies. The deferred elective procedures roughly is going to be about 425 million cases based off of what we've heard from Kaiser Health News, the American Hospital Association, and some of our own internal proprietary analysis at TransUnion Healthcare. The COVID claims per AHIP we're going to be roughly around 65 million to 95 million. Now, as of April 20th, I haven't gone out and updated this. There's about there was the 750,000 cases. I think we're, like we saw from New York, we're about a million now. And so they're thinking, 65 million claims. So that's a lot to come up with, given that we're only, just over 1 million right now. So I'm not sure exactly where AHIP was getting their numbers and where they were at from a claim standpoint. Maybe there's going to be multiple visits and multiple encounters for some of the patient populations. But even with that somewhat of aggressive analysis, it's less than 3% of the overall claim volume, and the deferral of the elective procedures was a much, much larger wedge in the overall claim volume too. So you've heard talk that from the payers, the reason I have this here is that, well, they're going to have to maybe increase premiums or they're getting a detrimental impact. Well, they had a windfall of claims that did not happen that they were still accepting premiums for. And so all those orthopedic and cardiac and elective procedures, high cost MRIs and things that they had premiums and actuarial risk for went away for 2 months. And they had some replacement of that with COVID, but it wasn't all of the pizza slice. So just something to keep in mind as you're starting to hear about whether hospitals are replacing their revenue with COVID claims or payers are seeing increased risk with that as well. We'll talk about unemployment here for a minute. The gray bars in this graph below just talk about different periods of recession, and then this blue line is the percent of the population that did not have a job from 1950 until now. We were doing pretty good coming out right before all this happened, but then we just basically fell off the map. It's like the map writer or the graph writer fell asleep, and right now we had the one of the absolute lowest levels or highest levels of unemployment since we've started, and so this is very, very troubling for our country. We're going to talk about this 40 million that are unemployed. I think you're starting to see them come back as the economies open up, but what type of job are they coming back to? Is the place that they're coming back to going to start? I don't know about you, but some of my favorite restaurants in town aren't coming back. They just didn't make it. The chains will probably make it in the franchises, but the hotel chains, a very large car firm, Hertz, is filing for bankruptcy. So this had economic impacts, and it hit hospitals too. Hospitals was in the top 3 or 4 industries, healthcare was, that had a very high propensity of folks that actually lost their jobs during this, mainly related to those elective procedures being bumped out. As far as insurance and that unemployment, you're going to see about a 27 million with an M, gang, loss in employer-sponsored insurance across the country. And in Florida and Georgia, you can see that in the lower right corner there, regions that we're talking to today, South Carolina, North Carolina, that number is pretty high. Florida's 2 million plus, Georgia's in that million plus range, and so South Carolina's in that 500,000 range. North Carolina is in that, or I'm sorry, South Carolina's in that 100,000 to 500,000, and North Carolina's in that 500,000 to 1 million range. 1 million of your residents in North Carolina, for example, are going to lose the insurance that they were on, according to this analysis. And I've seen several other reports that have shown this. That means that they're going to transition to other types of insurance, likely not commercial. Whenever something bad happens in our country, this comes from Kaiser Family Foundation, you see Medicaid kind of pick up the slack. We had a recession in 1998. And in 2008, and then we're going to probably get one. This one kind of caused it. It was coming anyway, but I think it made it worse. And they're projecting, and I think they're very, very conservative here. I think we will absolutely see ranges of 10 to 15% Medicaid enrollment increases. It's certainly going to hit double digits. I just don't know how prevalently in the year of 2020, 21, 22. And notice the timeline too. It's not like you're going to get them all in 2020. We will experience this crest of Medicaid over the next probably 3 to 5 years, because that's what we've seen from this data before. What does that mean? Well, as insurance disruption happens, it's certainly going to impact you all's payer mix and how your reimbursement streams work. This graph here is from Oliver Wyman, and it shows 3 different kind of scenarios of unemployment, 10, 20, and 30% respectively. We're roughly in that light blue turquoise. We're about 20% unemployment. We haven't quite hit the 30% mark. But if you look closely at that, that substantiates that United States map I showed you earlier. We have 97 million, they were saying, folks as a baseline in large employer-sponsored insurance. That's going to drop to 70 million. There's 27 million right there, just in that one tranche. With that, you will see an increase, of course, in individual plans exchange plans, and Medicaid, as I just showed you. And then unfortunately, you will also see a very dramatic increase in the uninsured. And so your patient population that comes in is going to fundamentally have insurance disruption and also probably payment headwinds from either high deductibles or benefit changes as they come back. And we'll talk about some best practices and how to manage that. But this is a very important trend, and the scenario brief that I talked about talks through this. We've actually created a payer brief as well at TransUnion. I'm happy to send that along, just talking about these nuances that are going to be things that are kind of ripple effects that happen from what COVID happened in terms of how patients are going to fundamentally be covered for their care going forward. So there is going to be significant disruption in insurance coverage. I went over most of these. This is kind of a summary slide. Carrier coverage will vary significantly on the plan. You're seeing some waive authorization requirements and out-of-timely requirements. Some aren't and some are. We talked to our advisory board. They mentioned that they're seeing much more help from the government payers than they are from the commercial. Employer-sponsored insurance will lose membership as unemployment rises. Medicaid and the exchanges are going to certainly increase. I think you're going to see premium volatility and overall uncertainty in the fully insured market. I think employers are going to start switching plans come their next plan year because they've lost money and they're going to look to save costs, and it's easy to move to like a high deductible health plan, which of course will impact your collection and risk efforts as you're modeling out your contracts and your administrative expense and your cost to collect as you go forward. If these premium increases occur, you certainly, I think, will see employers do that, as I mentioned, and you'll see growth in these plans that I have I've been a proponent that we should kill someday, but I always say death to deductible, and I think they're actually going to snap back in a volatile way as we move forward. You've seen the bills in the summary. I only have one slide on it. It's just for folks that may wanted to get some information in terms of timing and what they did. I have a whole nother deck, and happy to come back to Region 5 if we want to talk through what's going on with each of these packages and how you get the money. Most of these have sunsetted, and there's a very few that are still open from a payment standpoint. And I think as you see more versions of these bills come out, they will talk about putting more money into the provider relief fund. The HRSA fund right now is pretty active in terms of the uninsured and making sure that you're getting your dollars for your COVID testing and treatment there. And TransUnion has run some reports for hospitals to help in that area. But basically, walking through these, the CPR SAA came out in March, and that really was just to throw a hand grenade at COVID to help ensure that we had testing and preventive and education out there once we started learning about it. About 2 weeks later, FFCRA came out to help stabilize the employer market from an FMLA and sick leave and also address testing. The CARES Act, which we're all probably very familiar with, came out at the end of the month. And then had the $2.2 trillion bailout for hospitals, airlines, and small business, and also that $1,200 check that went out to everybody. And then finally, this relief package 3.5, the PPP HEA, came out about a month later. About $500 billion there, sorry, in terms of small business loans, because that money went very quickly. Also replenished some of the hospital funding, and then also addressed rural and some other areas. And then we've got the HEROES Act, which passed the House. It's very likely to be killed in the Senate. We have folks in D.C. that have mentioned that you probably won't see this thing come back until we figure out what's going on with police and law enforcement reform, because that seems to be the crisis du jour for Washington right now. And until that gets figured out, this may not get revisited, and that's unfortunate. And so they won't. You may not see a bill be reviewed until next month at the earliest. And so, and right now, I think this is dead on arrival. It's got some very, very partisan language in it that the sides of the aisle just really can't agree on. And so we'll see where we end up. But it's $3.0 trillion, another $100 billion for providers. I do think we'll see something, gang, but I don't think it's going to be in the form of the HEROES Act. $72 billion has been released in the CARES funding so far. This is a breakout of where those dollars have been released. About $30 billion went to the based off fee-for-service revenue. The government kind of got a slap on the hand when they did that, because per this graph, you saw distributions going to hospitals based off of that. But you look at like the grand state of Minnesota, no offense against them, they got more money than New York, and that makes no sense, right? So that was the first distribution that came out. So the government said, okay, well, let's base it based off your revenue for the year. That was a little bit better. And then they finally got it together and said, hey, let's base it off your hardest hit regions. That was at the end of April, and they released another $12 billion there. And then they've got $28 billion reserved for SNFs, providers, and high Medicaid volumes and future hotspots as they watch, and then $10.4 billion for rural providers and Indian health services going forward. Hospitals are going to struggle with paying back these loans. I wanted to take a minute to talk about this. I know a lot are on the clock in terms of they took that advance payment and now are quick as possible getting those elective procedures back on their books and doing them. And it's not happening at a pace that's nearly fast enough to where the payment expires. And so HFMA did a very nice article on this. The link is below, but the quote in the lower left corner is significant. They do not believe it's possible. Chad Mulhavey, if you've ever heard him speak or know him, he's a wicked, brilliant guy that knows the legislation and understands what's going on at HFMA. Very, very good source. He says he does not believe that providers are going to be able to get that volume in terms of when payments due. So think of this as a balloon payment concept. And their volumes in the next 12 months will be much lower than their volumes during the same time frame. And so CMS is going to have to figure out how they're going to enforce this or not. I think you'll see that in some of the language coming out in the next package. HFMA put forth recommendations here. They have sent letters, but saying that you need some forebodings. The recruitment percentages need to be less. They need to extend this period of time and certainly reduce the interest. And so know that that's happening. It's in flux. I encourage you to read the article, but basically you've got this clock ticking of the dollars that were advance paid, and the elective procedures that are coming back aren't coming back at the rate that you would have liked to, and we certainly will evaluate that and research that here more as we go. Good transition into elective procedures. Beds were empty for most of the month of March and April. I'll walk through a timeline here with you really quickly. I'm not going to go into the blue and red very much, but back in probably early March, when the Surgeon General announced that the elective cases were there, that first downstream red bar, I put this timetable together and I said, okay, if they did that, what are the things that need to happen as we go forward? And then the Fellow American College of Surgeons announced guidelines there in yellow around April 19th and said, here's how we're going to come back. And so I projected, based off some analysis that I have and some others and some folks at TransUnion, what we thought the projection path was going to be for providers going forward. And so, obviously we had the first COVID case in February. California sheltered in place. Yay, we led the world in March, and COVID cases, not a great thing to celebrate. Certainly had 42 states under a shelter-in-place order. And then in the middle here in yellow, we had states issuing return-to-work plans, the CDC announcing that you could bring your elective procedures back, and then finally a projection of where we'd see providers there at the left achieving 25% elective procedure capacity, providers achieving 50, 75, 90, and so on. I know all of your organizations, hospitals that are on the phone, have a plan to recovery. I know that plan is probably talked about on a weekly basis. I just thought this might be helpful so you can kind of benchmark. And we are seeing this, at least on our side, from our client base of about 2,000-3,000 clients in hospitals across the country. They are right around that 80% recovery rate. So we're spot on in terms of the timing of when we thought. We'll see if they achieve 90. Notice that it doesn't go to 100. I do think there's going to be a deficit no matter how much surplus or backlog you have as an organization. There's this fear factor, and there's just this also just general recovery factor. You're just not going to get all the fish back. All those elective procedures aren't going to come back, and I think you'll run at a deficit for a few quarters. And that might be the new normal for you as an organization as well. It's going to take time to come back. I've shared this with CNBC and several others, this graph, when we were doing some media interviews. But the blue line is that's similar to that trough graph that I showed you, but basically the run rate. Most providers and hospitals and ambulatory surgery centers can run at 120% capacity. That's doing things like surgeries in the evening, or maybe I've even heard some considering running 24/7, extending their high-cost imaging and elective procedure schedules into the weekends, that type of thing, so they could get up to that 120%. That's that gold bar there. Well, they recommended that all the cases got rescheduled right in March. That meant there was this trough that was created through the month of May. The providers have met your guidelines in June. You start doing your procedures here, and your cumulative backlog was being created. You're going to have about 3 to 4 months of recovery because your capacity will outlay your your volume that's out there. So it's going to take time to come back. So that's the good news. The bad news is I think you're going to drop below, as you see that little tail over there, what your normal run rate was for your elective procedures, just given this fear factor that patients have. Most organizations aren't fully prepared to come back, or at least weren't when this survey was done in April. Biggest obstacles were testing, which I talked about, PPE, which I think has been fairly managed for the most part. I think most of you have managed that. What the volumes look like, as we just went over. Then finally, I tell people a lot of people don't understand that hospitals are a restaurant, a hotel, and a physician's clinic all rolled into one. And so all of those things have to happen in a hospital for it to open up and start seeing elective things, not these emergent things. And so they've kind of had to shoehorn a lot of those policies, procedures in place, get the staff up to speed and others. But it's important to understand that despite it's not a light switch, it's a dimmer switch. It's going to take time to bring these things on. You're not just going to flip them all on right away. Another interesting survey that we did surrounds about half of patients were hesitant to return. So that's why I think there's going to be a deficit in terms of your volume. They had mentioned that they plan to reschedule once they no longer believe there's a high risk, or there's a guideline of some sort that's published by the government or the organization that says it's okay to come back. I know you're experiencing this. I've talked to several hospitals that have said that they've got active marketing campaigns and outreach to patients to try to get them comfortable in coming in, to get a hold of them, get those pre-surgery testing things coming in. We are starting to see quite a bit of elective procedure volume transactions happening at TransUnion Healthcare, things like eligibility checks, estimates, financial assistance inquiries, those types of things. So we're starting to see the market pick back up, but certainly there's this fear factor out there, I call it, and that's present with about half the population based off the survey that we had done in February and March. So some short-term strategies to recover, celebrate these discharges. I'm on LinkedIn. Please connect with me if you like, but I saw a hospital in White Plains, New York, applauding their 100th COVID discharge or whatever it was, or 1,000th. I think that's important, gang. This was really hard. I've been through mass casualty drills and mass casualty actual events at my hospital where we had a 12-day downtime with an EMR. We also had a 4-day flood. And those of you that have been through them know, once you've been through that, it's exhausting and tiresome. And this was a really big deal to go through. And you'll probably experience it again, or maybe not in your careers, who knows, but celebrate what you're doing, stay on where you're at from a short-term strategy, really communicate with your staff and figure out what things you're doing well, how many lives you've saved, how many people you've helped with insurance, those types of things. Your patients are going to come first through this. These are questions they're going to ask. After COVID, is it safe to come back? I lost my job. How can I make payments? Will my insurance cover this? Have I met my deductible? Do I have to pay everything in full? What the majority of patients don't know about financial assistance, how can I qualify for that? These questions have been there, but the safety one and I just lost my job, I think are ones that you're going to have to navigate a lot more now. My CFO used to tell me all the time, blocking and tackling, Jonathan, get back to basics. These are the 4 big basics here in blue. As you're bringing back these elective procedures, got to check eligibility, got to verify that it's covered and the patient can afford it, and got to collect it, both from patient and payer. And those steps sound simple, but I can't tell you how many hospitals, I've been in hundreds of them, where they're running eligibility, but they're not doing anything with it. It's like a train passing through the night. You got to stop, switch it to self-pay if it comes back as not covered, and then let the patient figure it out or the carrier figure it out with you. Otherwise, you've made the choice to do it for free. And then you're verifying those procedures. And if you can't pass these gates, you got to stop, because you have a choice of doing that procedure for free or coming back and actually getting some kind of funding mechanism established before you start. Estimating is important. It's very important now. And it's not about the estimate. It's not necessarily even about the collection. It's about setting up a payment plan for that patient over time. And I think we had recently partnered with VisitPay, and they have this 5-tier strategy here that talks about how important it is right now to really engage the patient as payer. They should be able to self-service their payments just like if they bought a couch or a car or a television set or an airplane ticket or anything else, and should be able to interact with your revenue cycle just like they interact with Amazon. And it's not that hard. and they could set up a line of credit. They could set up payments over time, and that allows the hospital providers to be empathetic in terms of what types of communication that person wants now, where will it be tailored from a financial standpoint, how can those personalized loans and offers be made in a way that allows the patient to pay within their ability to pay. The relief can be help those that really need it, and also empower those that have the ability to pay in a seamless, somewhat frictionless fashion, and allows for efficient kind of cost to collect and revenue yield across your patient population. So nice 5 pillars here to walk through. Mobile is, I've heard this term leapfrog from Guidepost and those from Navigant and others. I love it. I think it's time for hospitals to move paper to plastic and providers to get out of 1985 when it comes to paper statements. And I think these things pay for themselves over time, and people want to pay their bills. They just need to trust their bill. And you hear a lot of headwinds in the market about, well, we can't estimate and we can't get to where we need to be. You can estimate a lot, gang. I ran a revenue cycle, and you can estimate things that in a relatively close range and to make sure where you're at. And things that you can't, you can accept down payments on and have conversations. We've all talked to car mechanics, plumbers, and contractors in our homes before as consumers, and we've all received estimates, and we've all received ranges, and we're all comfortable with them. So these things don't have to be down to the penny initially. In some areas they can't, but the point is to have an engaged financial conversation with patients during this COVID disruption, because it's going to be different. And if you suppressed your statements during this, which a lot of hospitals did, and then lit them back up last month, those things marinated for 30, 60, 90 days. That's not going to work. You know, a lot of those payments are going to default. A lot of people are going to be confused. Their financial situation changed. So it's time to leapfrog into a mobile strategy, I think. The last few slides here, and then I'll open it up for questions, really are going to surround just what can we expect over the next few months in terms of what's going on in hospitals and where we're going to end up. Really, it's going to be a back-end focus. I think after you get the patients figured out and the intake and the elective procedures back and how those payments, it's going to be, okay, now what's my revenue cycle look like? Where are my dollars stuck, and where can I help fix them? Where do I have coverage for and payments for patients? Where do I not? What patient payments and what payer payments are out there that are not performing according to what we contracted for? How are my year-end filings going to work from Medicare bad debt and DISH standpoint? How am I going to get paid faster? Revenue is very important right now. Every claim is tied to a profitable or not profitable year, and you're running probably in the red, many of you, and coming back into the black is a function of making sure you're maximizing your yield on every single claim and really mitigating those denials. And so a lot of these problems were here before. I'm just saying, I think certainly COVID amplified them, and it'll be important to focus on them and really prioritize where you're at from a cost control standpoint. So a lot of vendors, I'm sure that you have, that invoices are coming. Please reach out to them. Reach out to us if we're one of your business partners as well. But it's time to look at all these different things that are going on and really understand, do you need 6 of one thing? I had 26 different vendors at my hospital when I was running my revenue cycle, and it was just too many. And we're consolidating them. So if you're looking for ways to save costs, like your VP of revenue cycle or your CFO has said, hey, we need to find 5% somewhere, any way you can, staff, invoices, reach out to vendors and look at that, perform an inventory and go, hey, do I need eligibility from 3 different places? This guy's doing DISH and this one's doing MBA, TPL. Maybe I can put these 2 together. Look for one that has a holistic solution to where you can help save some cash on the back end, but it's a good time to kind of evaluate that inventory and really work on your cost control. HFMA's had some articles on this as well, and I highly encourage you to take a look at them just to make sure that you're kind of checking. It's almost like spring cleaning, right? And getting down to the most efficient revenue cycle and where you're at. I'll talk about where to start tactically here. The step to get these elective volumes back has very many steps. This comes from the advisory board. Is it safe to bring people back? Which ones should we bring back? I've talked about folks have, like, for example, prioritized based off acuity. They're following the Fellow American College of Surgeons areas there. But within that, you still can consider maybe turning on MRIs before CTs or those types of things. As simple as that sounds, just to try to get that volume and that cadence and that revenue maximized as quickly as you can as you're coming through. this path is certainly going to take 2 to 6 months, depending on the readiness of the organization and the amount of backlog that's there. The communication pieces on the right are paramount. Staff has to be on board to handle those questions I talked about. Is it safe to come back? How often do you clean your rooms? Can I defer this later? I'm not going to be able to afford my bill. All of those types of things. Can my mom come visit me? All kinds of weird, new, and fun FAQs are going to be happening, and the staff and the patient and the providers all have to be on the same page as you're recovering these volumes. HFMA put this article together. I really liked it. They gave kind of 4 tenets to recovery. Human capital, make good choices, not hard choices. Enable that critical recovery. Those elective surgeries and scheduling are the key to the revenue stream and financial viability for many, many organizations. So you're seeing a lot of organizations quickly hire or maybe even upstaff there to where they can increase their capacity like I talked about. Identify roles as investments, not as costs. I thought was a great point. Revenue restoration, all of you have that plan I talked about, how you're getting back to elective procedures. Engage your payers. I don't think I've ever seen the relationship, at least before this happened, between providers and payers be more adversarial. It's time to kind of put the olive branch out there, gang, and go, hey, what can you do to help us? And pick up the phone and call United, Cigna, Humana, Blue Cross Blue Shield, Anthem, and say, hey, and Cigna, what can you do? What can you do for me? You know, can you increase the out-of-timely filing requirements? Can you relieve some of the auth requirements? At our next JOC, can we figure out what it is that we can do? When it comes time for contracting, let's try to work on some things to where we can prevent ourselves from being exposed to this type of risk next time. And very, very important to kind of make that step. Minimize those barriers from the insurance level, get the rules, hardwire them, look into those things, and try to work with them where you can. I know they're kind of, you're stuck between a rock and a hard place, but it's an opportunity when something like this happens. Supply chain, I think you've worked on too from a PPE standpoint and others. Cost reduction, that's going to be the probably the strategic priority du jour for most of the year. There's the easy way or the right way, HFMA said. That typical, hey, find 10% across the organization will fail, gang, guarantee it. You're going to have a laser focus approach with this and get very creative in terms of the cost structure. Digital health can certainly help with the infrastructure. I've heard of hospitals increasing their virtual health and maybe decreasing their lease expense, things like that. Supply chain, starting to look at GPOs and some other things from a PPE and other standpoint. Investments in innovation and manufacturing. Reduce spending. Significant amount of care can occur in lower acuity settings. You saw that people aren't going to come back to the ED at the rate they used to. So structure your organization that way to where maybe primary care physician office hours are longer or urgent cares are more prominently marketed, those types of things. And then there's certainly an opportunity to deliver more health care more efficiently. And if you like that, go read the book that I got, because there's a whole chapter on how healthcare is being delivered in kind of a shotgun approach and how we really need to tailor it to the situation and help educate patient as payers as they move forward. And then finally, capital. As you rebuild and reshape your revenue cycle, capital's on hold for the most part at most organizations, but ensure as you buy and purchase and bring things back that you're not just recreating what was there, you're not flipping back on what you had before and trying to recreate the past. Invest for the future. Data share, collection analysis, telehealth, de-emphasize those brick and mortar things and really try to figure out how you're going to increase loyalty with your patient, create frictionless payment options, and really enable some of these things that may have been stuck before. You got to look at the opportunities created from COVID, not the challenges, as you're bringing back that path to recovery. HFMA also talked about the return to financial viability. Certainly these elective cases, I've kind of beat that drum, but that's the first step. Virtual billing, virtual financial clearance is something that fascinates me right now, and I encourage you to research that as well. Like, how are ID cards and insurance cards going to come to the organization with virtual health? What's that look like? Can people take pictures of them and send them to you? Is there a portal? Is there a way of doing that? Because they're not going to see the receptionist or that front end registrar as much as they might before, and nor would they want to. And is there a way to make that more seamless? Claims cleanup. A lot of you have a bubble in the hose, be it from an ED surge from COVID or just some of this insurance disruption that I've talked about that have happened. How are you handling that? How are you staffing for it? How are you looking at that inventory and understanding where there are detriments in payment and where you're heading? Every claim right now from a claim hold standpoint is revenue for the hospital, and it cannot be delayed further. And I've talked to so many hospitals. They delayed the claim. The payer told them to delay the claim because they haven't had the rules in place. Got to send them fast and do the best you can. Cost control is going to be, as I mentioned, the strategic priority. This is a dimmer switch too, gang. We're not just going to immediately come back to where we were next March. I think it's going to take us a couple years to kind of fully come on plane from this stuff. We may get to financial recovery in months, but I think it's going to be years before we see things as normal pre-COVID, and we may never get there for all we know. Last slide I have today, and then I'm going to open it up for questions, really surrounds kind of the 7 steps to financial recovery. This comes from the advisory board. I love this, but double down on your AR and your inventory efforts. Absolutely. Get your cash flowing, find out where that is and what you can do to fix it. Adjust that financial experience to make sure that your patients didn't get caught up in this, either from a care detriment or a payment detriment or an access detriment standpoint. Very, very important to reach out. I know that was a strategic priority for many, many organizations. Now it's an imperative. If you don't do it, they're going to go somewhere else because they had to during COVID and they know there's choices. Reallocation of revenue cycle staff, a tremendous opportunity to cross-train. I know a lot of you did that, but the front-end the front-end staff could learn how to be a biller, and a biller could learn how to be front-end staff. I think they'll learn a lot and manage the revenue cycle through this, and continue with that. Don't devolve back to where we were. Beginning of the year, my revenue cycle, we were really trying hard to cross-train where we could and help educate and be as transparent as we could across most of the operations. Redesign your COVID-19 claim strategy. What does that look like? What are those modifiers looking at? How are your HRSA payments going to look? How do those submittals look? What portals do you need to be? Where are those modifiers? I've got some resources from the AHA and AMA I'm happy to send along that have the most updated codes and what's going on to make sure that those claims aren't bouncing and that you're getting paid the proper amount upon a submittal. Payment accuracy is very important. If there's any time to hold the payers accountable, it's now. Make sure you're scorecarding them and you've got really good baseline data. And then especially as there's things being talked about with waiving of testing and waiving of cost share and waiving possibly of treatment, very important to make sure you're getting paid the right way and benchmarking that as you go forward. Finance is going to have their hands full over the next few quarters in terms of their bad debt, Medicare beneficiary bad debt, their dish payments, their cost reports, those types of things are certainly going to have some fundamental. Buy them a beer next time you see them. They're having a rough day. And then finally, improve your debt position. I think that's kind of an obvious one, but how are your investments and things going to recover as you move forward, and what types of opportunities reside there? I know that was a ton of information in a short amount of time, but I promised I'd have about 10 minutes here at the end, and here we are. I'm happy to open it up to any questions. I can go back to a slide and talk through it, but we'll open it up and see if anybody has any questions for me. And you can put those in the chat, I believe, and I'll try to hop in there and see if anybody had any and where we're at. There's one in here. Yeah, go ahead. Sorry.
Oh, yeah. So I was just going to say, Jonathan, while we're waiting on, you can use either the chat box or the Q&A function, but there is a comment here in the chat that I thought maybe you want to read and react to. Telehealth and remote monitoring will continue requiring providers to re-engineer the services they provide to retain sustainability. Costs need to be reduced significantly as reimbursement for telehealth and remote monitoring will be reduced by health plans. There was great insight at Senate hearings this morning. So I thought maybe you would want to comment on that comment.
Absolutely. We haven't seen prevalent payment parity, I call it, say that 5 times fast, right? For telehealth across Medicare to the commercial side. But you're seeing, especially out on the East Coast, I believe it might have been the Carolinas, had a health plan that is going to allow for telehealth reimbursement parity or the same fee as an in-person visit for perpetuity. So they're going to have it forever, as long as that plan is there. That's great. All the plans have to do that, right? Because if only some do, that causes inconsistencies in your revenue streams. I think this is a great point. Payers aren't dumb, gang. I used to work for one. They know that it's going to cost an organization fundamentally less over time, not now, but over time, to deliver a virtual visit versus an in-person visit. In terms of lease, staffing, those types of things, it'll just become more efficient for a clinician to deliver it that way, and they might even be able to see more patients. So you will see a deficit in payment occur over time from the payers, and that'll probably be cascaded. It'll pay at 100% now, but it might be 98% next year, 95 in 2022, 90. And you could probably see Medicare do that as well, because they're going to expect cost control to happen. And, I've heard this said at many conferences I've been at in the industry. Payers are not ever going to have a hospital's best interest in their mind. They're going to have their members' best interest in their mind. And with that, they have a cost control and shareholder type things that come up. And so you have to defend as a provider what your costs are and why you need to have those things there and why you need that level of reimbursement or that technology to deliver it. And I think it's an opportunity to collaborate with the payers to say, hey, what's our virtual health plan look like from a delivery standpoint to your members and a reimbursement to us? And how can we save costs as a whole through it? And have that type of conversation with your payers. And thank you for that. I'll go out. I was busy preparing for this morning, but we'll absolutely go look at that recording of the Senate hearing. I'm a Congress nerd, so I want to go hear that. So thank you for that comment.
Okay. Again, if you have any questions, please use the Q&A box. Jonathan, not to necessarily put you on the spot, but I think you do have some slides in your appendix, and I wonder
Sure.
while we're waiting if you want to just quickly trot through those a little bit and maybe pull out some highlights.
You bet. So scenarios that I mentioned, they've got some detail here in the back that just talks about and let me get this stuff out of my way here because I bet you guys can see that. Where we lost, and then unemployment now, of course, is at 40 million. It was at 37 million when this was created. That impacts income and insurance. I've been kind of beating this drum quite hard, but COVID happened, which impacted the economy, which impacted the jobs, which impacted whether or not you were working or not, which impacted whether or not you had insurance or not, which will impact whether or not you go get care or not, which will impact whether or not you can afford it or not if you went, and then what kind of funding mechanism is down at the end. So hospitals and providers are at the very end of that chain trying to figure out if what you had before is what you have now. So it's important to look at things like funding COBRA premiums if you haven't had that happen in your hospital. So did you recently lost your job? If you've got a high level of unemployment in your communities, that's a question my financial counselors and financial navigators do. When I was in my role as chief revenue officer, we would ask that in the financial assistance suites. We'd run a self-pay census every morning, and that was our batting order. And we had a census at my hospital. It was cute, of about 100 or so, 100, maybe if it got to 120, things got interesting. But we would, that meant that roughly about 10 to 15 patients on that census didn't have insurance. And so we'd go up to the room and we'd ask, do you not have insurance? They go, yep. Okay. Well, all your bills, $130,000 as of today. Did you recently lose your job? Because if you have COBRA, we might be willing to help you get that enrolled. And if you need help funding some of that premium, we might be able to help you because it's in our interest and your interest to have some coverage after you're done for whatever things that might need to be happen from follow-up visits or prescriptions being filled, that type of thing. And also just financially, we're going to both be on the hook for $120,000 as of today, and your COBRA premium can help fund some of that. So that's something to think about with unemployment. Those financial assistance policies, I've heard several organizations increasing the ceiling on those. So most cutoffs for most financial assistance policies are in the 400 to 600. I've seen some as high as 750, but maybe 1,000% of federal poverty was what needed to happen for COVID, given all the unemployment disruption. And you need to rerun those things and see where you're at and look at that. I don't know if any other questions came in while I was talking, but I can move on to the next one if we like.
We do. We have one other, and actually probably just time for this. Could you share any insight into how much telehealth visits are paid on average? It seems like they're much lower than an in-person visit. Also, do you have any insight on denials for telehealth?
Yeah, so telehealth was matched in terms of its fee schedule by Medicare when the executive order came out declaring this a national disaster, and they put an 1133 waiver out there. And I have information on that if you need it. Just feel free to email me. So Medicare, that happened. On the commercial side, it's kind of all over the place, right? But that payment parity that I talked about, I think is something that's going to happen because we were kind of forced into COVID. Like you couldn't have an in-person visit even if you wanted to. So the reimbursement schedule had to become on par or have parity with that as we went because there wasn't another option to deliver it. So I think you're going to see increased traction there and reimbursement there initially, and then I think that will detriment over time. I don't think it'll go all the way back down to whatever it was because it does pay, if at all, to your point about denials, less, or it may not even pay at all. And so you want to have payment parity there because your revenue stream needs to happen, especially with, physician clinics. They operate on a very low margin, high volume, low margin. And so you want to make sure that's there. So that's something to talk about, I think, with payers now and what they want to do and have that outbound collaborative conversation, as I mentioned. I have not seen yet, and I think it's too close to call, a high propensity of denials with virtual care yet. Those claims that got submitted in March and April are just starting to drop the EOBs and probably getting processed back at the hospital level. So I will track that very closely, and maybe the next time I do an educational session, we'll look at virtual billing and outcomes and see what those denials look like. But I haven't seen anything initial yet that had shown it. I know there's been a lot of denials and a lot of claim spins with not submitting them properly for testing, COVID, the ones that had COVID tests or the right modifiers, and authorizations, and certainly inpatient observation status, those types of things, which kind of are par for the course. But I hope that answered your question.
Great. Okay, well, thank you. It doesn't appear that there are any more questions at this time, and we are out of time. So, Jonathan, thanks very much for great information as always. As I mentioned, everybody, please hold the date for July 14th. For the Region 5 Virtual Education Day. We'll have sessions throughout the day. The featured session that is going to be hosted by the Georgia HFMA will be about protecting against cybersecurity threats. And then we'll resume with the Georgia HFMA Wednesday webinar series on July 29th with a session about analytics, intelligence, and revenue cycle. So Jonathan, you may want to sit in with us.
You bet. Be happy to. I'd like to educate. And if you guys need to get a hold of me, my stuff's here on the screen. And was my pleasure, and I was honored to present. And have a good rest of your quarter, you guys. We'll get out of this. We'll get out of it together. I know we will. Have a great rest of your week.
Right. Thank you. Everybody will be posting the presentation and the recording on the HFMA website at the end of the week. And please be on the lookout for that email from me with your continuing education credit form. Again, Jonathan, thanks so much. Everybody have a safe and great afternoon.
Take care. Bye-bye now.